So this week we're going to talk about personality disorders. So what is a personality disorder? Personality encompasses a person's underlying pattern of behavior, thought, and emotions, and the ways these interact to help or hinder how people relates to people or to different situations. And then we have three clusters. So for cluster A, people under this disorder are odd and eccentric. And we have paranoid personality disorder. Under this disorder, people are suspicious, distrustful, and hypervigilant. Then we have schizoid personality disorder. Person prefers to be a loner, detached, and unemotional. And then we have schizotypal personality disorder. People usually have unusual thoughts, perceptions, and behaviors. Then we have cluster B. People under this cluster, disorders under this cluster are dramatic and erratic. And we have antisocial personality disorder, so disregard and violation of the rights of others. Then we have borderline personality disorder. People under this disorder have chaotic relationships, abandonment fears, liable mood, impulsivity, inner emptiness, and self-harm. Then we have histrionic personality disorder. People tend to be superficial, theatrical, and attention seeking. And then we have narcissistic personality disorder, where people have grandiosity or lack of empathy. Then we have cluster C. Cluster C, under this cluster, people present anxious and fearful. So we have avoidant personality disorder. So it's avoidance due to fear of criticism and rejection. Then we have dependent personality disorder. People are submissive, clingy, and needs to be taken care of. And then we have obsessive compulsive personality disorder. People under this disorder are rigid, controlling, and perfectionistic. So the prevalence of personality disorders affects about 0.5 to 2.5 of the general population. Rates are higher in inpatient and outpatient settings. Origins and course of personality disorders are thought to begin in childhood, and they tend to run a chronic course if left untreated. The comorbidity rates are high, and gender distribution and gender bias in diagnosis. So gender bias, it does exist in this diagnosis of personality disorders, and such bias may be a result of criterion or assessment gender bias. So for general personality disorder, a personality disorder is an enduring pattern of inner experience and behavior. The pattern significantly deviates from cultural norms. The pattern is pervasive and inflexible. The pattern is stable over time, and the pattern leads to significant distress or impairment in social, occupational, and other important areas of functioning. The next one we have is paranoid personality disorder. So people who are paranoid or scared, and scared people often arm themselves, and caution must be exercised. Paranoia will continue even in the face of irrefutable evidence. People with this personality disorder may be hypersensitive, easily insulted, and habitually relate to the world by vigilant scanning of the environment for clues or suggestions that may validate their fears or biases. The next one we have is schizoid personality disorder. So this disorder is characterized primarily by a profound defect in the ability to form personal relationships or to respond to others in any meaningful emotional way. These individuals display a lifelong pattern of social withdrawal, and their discomfort with human interaction is very apparent. They have difficulty understanding social cues, may seem emotionally cold and distant, will often be loners, even to the point of alienating their families. Affected individuals may be unable to form intimate attachment to others and simultaneously demonstrate a rich, elaborate, and exclusively internal fantasy world. Then we have schizotypal personality disorder. So this disorder is characterized by a range of interpersonal problems marked by extreme discomfort in close relationships. So odd, even bizarre ways of thinking and behavioral eccentricities. These symptoms may include ideas of reference or bodily illusions. People with this disorder often have great difficulties keeping their attention focused. Conversation is typically digressive and vague, even sprinkled with loose associations. They tend to drift aimlessly and lead an idle, unproductive life, choosing undemanded jobs in which they are not required to interact with other people. It has been estimated that 2% to 4% of all people, slightly more males than females, may have this disorder. Because of the symptoms of schizotypal personality disorder so often resemble those of schizophrenia, researchers have hypothesized that similar factors are at work with both disorders. Schizotypal symptoms are often linked to family conflicts and to psychological disorder in parents. Researchers have begun to link schizotypal personality disorder to some of the same biological factors found in schizophrenia, such as high dopamine activity. The disorder has also been linked to mood disorders, especially depression. And then we have antisocial personality disorder. So people in this disorder, with this disorder, display a pattern of disregard and the violation of rights of others, sometimes described as psychopath or sociopaths. People with antisocial personality disorder persistently disregard and violate others' rights. Aside from substance-related disorders, this disorder is the disorder most linked to adult criminal behavior. The DSM-5 stipulates that a person be at least 18 years of age to receive this diagnosis. And most people with antisocial personality disorder start to display some patterns of misbehavior before the age of 15. Affected individuals are likely to lie repeatedly, be reckless and impulsive. They have little regard for other individuals and can be cruel, sadistic, aggressive, and violent. Research indicates that 2 to 3.5% of people in the US meet criteria for this disorder. The disorder is 4 times more common in men than women. Because people with this disorder are often arrested, researchers frequently look for people with antisocial patterns in prison populations. And studies indicate higher rates of alcoholism and other substance use disorders among this group. Children with conduct disorder and accompanying attention deficit hyperactivity disorder may have greater chances or developing antisocial personality disorder. Then we have borderline personality disorder. I just want to take a second to talk about the people under the population specifically under this disorder. When I started grad school, there was always talk, well, not always, but there was talk amongst either professionals or even in the clinical sites that I was a part of, where borderline personality disorder is often seen as the most difficult disorder or group of people to work with, or people under this disorder are helpless. That's also a bias that I've recognized in our field, that, you know, when someone hears borderline personality disorder, there's going to be some sort of stigma around it. And then being a BPD, or I should say DBT clinician, I've experienced the opposite. I'm not saying that everyone can be helped or can get better that present with BPD, but I have seen firsthand working with this clients, this population, that they can make changes, and I've seen it with most all the clients I've worked with. So I don't think that the stigma that surrounds this particular population is accurate in the sense that they're unhelpable. So just a little, information for you all. So moving on. So people with this disorder display great instability, including major shifts in mood and unstable self-image and impulsivity. Interpersonal relationships are also unstable. People with BPD are prone to bouts of anger, which sometimes result in physical aggression and violence. Just as often, however, they direct their impulse anger inward and harm themselves. Many of the patients who come into mental health emergency rooms are individuals with this disorder who have intentionally hurt themselves. Their impulsive self-destructive behavior can include alcohol and substance abuse, reckless behavior, including driving, reckless driving and unsafe sex, and suicidal threats and actions. People with this disorder frequently form intense conflict-ridden relationships while struggling with recurrent fears of impending abandonment. Between 1 and 2.5% of general population are thought to suffer from this disorder. Close to 75% of those diagnosed are women. The course of this disorder varies. In the most common pattern, the instability and risk of suicide reach peak during young adulthood and then gradually wane with advancing age. Some features of the disorder have also been linked to biological abnormalities, such as an overly reactive amygdala and an underactive prefrontal cortex. In addition, sufferers who are particularly impulsive apparently have lower brain serotonin activity. Close relatives of those with BPD are 5 times more likely than the general population to have this disorder. Another thing too, I want to add to this, I work with couples where one partner is presenting with BPD, and it can be difficult, sometimes even challenging. But I do work with the NEBPD, which is an organization that helps give free, it's a workshop where we give free psychoeducate families or partners or children of those affected with BPD, basically DBT, and we teach them how to work with their loved one and understand their loved one. Also, I'm sure, well, I don't know if you are all aware, but Marsha Linehan, the creator of this theory, also had or suffered from borderline personality disorder. And you're going to notice that a lot of clients that come in that present with BPD are people that have didn't get validated while they were young and were dubbed the over emotional family member of their system. And so as they're growing up and they're hearing that narrative of, it's like walking on eggshells with you and you're always so sensitive and I can't tell you anything, we allow a space for them in the therapeutic setting to express themselves, but also the component of mindfulness of, okay, so you got upset that your partner didn't let you shop today. Like, let's talk about it. What's going on, right? And so we start to break down what we call a chain, an interaction chain, where we break down the person's days that they've had that have been most highly reactive. And we've helped them find that emotional regulation, right? So maybe there was a bill due the same day you wanted to go out on a shopping spree, right? That impulsivity. And so we help them understand it from a place of non-judgment, because the population with this disorder, they're very black and white, right? There's that dichotomy of it's either yes or no, and there's no in between. And so we're helping them find that flexibility of being open to other people's perspectives or even their own perspective, right? So that is borderline personality disorder. The next one we have is histrionic personality disorder. So people under this disorder present excessive emotionality and attention seeking, a strong need to be the center of attention, drama seeker by nature, lively, dramatic, vivacious, enthusiastic, and flirtatious. Approval and praise are the lifeblood of these individuals. People with histrionic personality disorder are often described as vain, self-centered, and demanding. Some make suicide attempts. They often often manipulate others, once believed to be more common in women than men. However, research has suggested gender bias in past diagnoses. Statistics suggest that 2 to 3% of adults have this personality disorder, with males and females equally affected. Next is narcissistic personality disorder. People with narcissistic personality disorder are generally grandiose, need much admiration, feel no empathy with others. People who are affected by this disorder exaggerate their achievements and talents and often appear arrogant. People with this disorder are seldom interested in the feelings of others. Many take advantage of others to achieve their own ends. Around 1% of adults display narcissistic personality disorder, and up to 70% of these are men. This type of behavior is common among normal teenagers and does not usually lead to adult narcissism. Then we have avoidant personality disorder, a pattern of social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation, avoids contact in order to prevent projection, considers themselves to be socially inept or personally unappealing to avoid social interaction for fear of being ridiculed, humiliated, rejected, or disliked. They generally avoid becoming involved with others unless they are certain they will be liked. The main coping mechanism for those with avoidant personality disorder is avoidance of feared stimuli. This disorder is similar to social anxiety disorder, and many people with one disorder experience the other. Similarities between the two disorders include fear of humiliation and low self-confidence. The key difference is that people with social anxiety disorder mainly fear social circumstances, while people with avoidant personality disorder tend to fear close relationships. As many as 1 to 2% of adults have avoidant personality disorder, and men as frequently as women are affected. Then we have dependent personality disorder. So people under this disorder have a pervasive, excessive need to be taken care of. As a result, they are clingy and obedient, fearing separation from their loved ones. They rely on others so much that they cannot make the smallest decisions for themselves. The central feature of this disorder is a difficulty with separation. Many people with this disorder feel distressed, lonely, and sad. Often they dislike themselves. They're at risk for depression, anxiety, and eating disorders, and may be especially prone to suicidal thoughts. Research suggests that over 2% of the population experience the disorder. Research suggests that men and women are affected equally. So obsessive compulsive personality disorder is the next one. So people affected with this disorder are so preoccupied with order, perfection, and control that they lose all flexibility, openness, and efficiency. They set unreasonably high standards for themselves and others, and fearing a mistake, may be afraid to make decisions. These individuals tend to be rigid and stubborn. They may have trouble expressing affection, and their relationships are often stiff and superficial. As many as 1 to 2% of population have this disorder, with white, educated, married, and employed individuals receiving the diagnosis most often. Men are twice as likely as women to display the disorder. Many clinicians believe that obsessive compulsive personality disorder and obsessive compulsive disorder, the anxiety disorder, are closely related. While the disorders share similar symptoms, researchers have not found specific link between them. Then we have personality change due to another medical condition. So here we specify whether liable type, if the predominant feature is affective lability, aggressive type, if the predominant feature is aggressive behavior, apathetic type, if the predominant feature is marked apathy and indifference, paranoid type, if the predominant feature is suspicious or paranoid ideation, other type, if the presentation is not characterized by any of the above subtypes, combined type, if more than one feature predominates in clinical picture, and unspecified type. Then we have other specified personality disorders. So this category is used in situations in which the clinician, chooses to communicate the specific reason that the presentation does not meet the criteria for any specific reason, that the presentation does not meet the criteria for any specific personality disorder. This is done by recording other specified personality disorder followed by the specific reason. Example is mixed personality features. Then we have unspecified personality disorder. So this category applies to the presentation in which symptoms characteristic of a personality disorder that cause clinically significant distress or impairment in social, occupational, and other important areas of functioning preponderate, but do not meet full criteria for any of the disorders in the personality disorder diagnostic class. I also want to just point out or I want to talk about the multicultural factors and lack of research. So given the vast amount of interest in personality disorders, it's surprising how little multicultural research has been conducted. Theorists have suspicions, but no compelling evidence that cultural differences exist or that such differences are important to the field's understanding and treatment of personality disorders. The lack of multicultural research, if of special concern with regard to borderline personality disorder, and theorists are convinced that gender and other cultural differences may be particularly important in both the development and diagnosis of this disorder. So as clinicians, we want to just, make sure that, we're being mindful of culture, of the person's background prior to diagnosing and assessing. Not all one size fits all. So if you're looking for example, if you're looking for a specific population like lower SES or, Hispanic Latinx community or Caucasian or African Americans to walk in the door and to be that cookie cutter of a personality disorder, that's not going to happen, right? Every person's different. So you want to be aware of your clients, right? Their background, their culture, and ask questions. Don't be afraid to ask questions. And again, these personality disorders are, I don't want to say they're complicated because they're not, but with treatment, you will see some resistance. For example, with borderline personality disorder, there are a lot of people in my practice who don't complete their treatment, or they figure that halfway in it's not for them, even though they're making wonderful strides to getting better. But some people are comfortable with the parts of themselves that they identify with. So anyway, I hope you guys enjoyed the presentation, and if you have any questions, don't be afraid to pop in on our student hours, Wednesdays for me, and of course, Dr. Lappins. And I thank you for your attention.